thank you, and of course, UNAIDS and Julio team for inviting me, and apologies that I was late. And so I say to Kenny I should be punished and put right at the bottom of the list to see whether there was time. But thank you, and it's a pleasure to be here, and it's my job in the next 5 minutes, I think, to shine a bit of a light on pediatrics and adolescents, just to make sure they're not forgotten. And we really are advocating for their own 90-90-90. It's really, really important, I think, that we don't let those two populations get lost in the bigger picture, but that we single out the first decade and the second decade and think about them separately. It is not altogether easy, because we're just beginning to disaggregate this data, properly and really get it together. But it's, again, my pleasure to bring to you Cape Town data. Frank's already alluded to this area, but I did think it was probably important to contextualize Cape Town within South Africa, since I saw that South Africa as a whole wasn't necessarily on the program this afternoon. So I'm going to quickly give a little bit of attention to that as well. And I have to speak really fast, because for me to do a talk in 5 minutes is unheard of. So, but I'm going to try and stick to that. So I do also want to just say, though, that I think sitting there felt like getting Prozac intravenously. I mean, I don't know who was here in 2000, but what has been achieved, and when I hear what has been going on country after country, it is extraordinary and amazing, and I am so glad to be part of this community, because we do stuff. And I'm very, 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 very pleased to be part of it. So here is South Africa's trajectory. You see adults, you see children, and I know I don't need to tell this audience, but the reason we single out children is children have been left behind. Adolescents are being left behind. We have to fix that. I think we're doing better on the children front. PMTCT has certainly helped that a great deal, because we're busy eradicating pediatric HIV, but children continue to slip through the cracks. But our big next problem are our adolescent population. That's across the world. So just to keep that very much alive. Since 2000, this is what South Africa's done. I'm so proud of South Africa. We're sitting on, in fact, this is a little bit old data. It's 2015. We're edging towards 3.5 million. We have the biggest treatment program in the world, and again, I'm very, very proud of that. We were edging towards really looking good on the second 90, but my country will move in September to universal test and treat, and then we'll have a bit more work to do again, but that's good. And we continue to chase the 6-odd million that we need to get onto treatment in the next while. As you can see, by province, it very much varies. There are 9 provinces in this country, and the number of people on ART in South Africa by province you see reflected there. And I'm going to talk a little more in depth about the Western Cape, which is constantly said as the province that's least hit. But what we have is a concentrated epidemic between the N1, which heads you to to Joburg from Cape Town, and the C on the right side. That is the whole of our HIV epidemic there. And we see rates amongst women of 1 in 3, 1 in 4. So, once you get into the concentrated areas, the low socioeconomic high-density areas, you see an epidemic pretty much like we see in other parts and in this province. So adults, how are we doing on the 90-90-90 targets in the Western Cape? You can see there it's a province that has the highest concentration of HIV experts as well. That's because it's a really nice place to live, I have to say. But we have also been blessed that our health systems are good there, and I think we've tackled this early. We've been going at it, and you can see we are making some headway, although even in our part of the world, there is work to be done, as you see. We have not got 90-90-90 across the board. And just sort of taking that out for you, but more in terms of percentage of HIV adults diagnosed, looking about 83. On ART, we have work to be done, 56%. It'll help when we're on universal test and treat. And those who are suppressed, we're doing better. What about children then? Of course, the leading causes of under 5 mortality, HIV/AIDS is there in big amount, and that needs to be, again, dealt with. I think we're going to see that begin to reduce because we're now treating earlier. But still, the top 10 causes of death in children 5 to 14 years, you see there both for young children who are males and females, HIV/AIDS is at the top of our list. So this, again, a tragedy that I hope we're turning around. Modeling data from Lee Johnson, just to look at total children on art. This again now is South Africa, as you see there, and then the Western Cape, we're a little ahead. This, is as we also begin to decentralize children's care, tend to be very central to begin with. We somehow thought that only experts could deal with HIV/AIDS in children. It's now decentralizing. I think we're getting ahead on this, but we've still got, again, a lot of work to be done. Now, interesting what's been happening, and this is really to illustrate this, is that this youth bulge that I think you've heard Ambassador Burke speak about, that's coming all together to Africa, is also coming in our HIV-positive children in adolescence. So we are seeing this age group grow up and into adolescence with all of the wonderful challenges that adolescents bring us. And they are wonderful, but they are real challenges, and that is coming at us like full force, and I hope everybody's ready. You've got your seatbelts on, because we're going to have to deal with this population in its entirety. So again, the other thing that's happened is we've moved treatment up earlier. That's great, because it means kids aren't dying, and so you see treatment going from 2003, 6, 10, and then 15. We're getting that treatment in early, and that's really important because kids are staying alive. So again, very nice. So total children on art has been growing slowly. You see the numbers there. The number being initiated per year is falling, which is, yay, great news, because that means there are fewer actually to treat. The age at art initiation, the proportion starting out under 1 has increased, and that's from 7 to 20%, and we are seeing less sick children starting on art because we're not waiting for them to get sick. So there you see it beautifully shown. This is across South Africa. And then this is IDEA data, 2008 and 2014, again making this point that these children are growing into adolescence, and we are, really mushrooming this age group. You're going to need adolescent-specific care. I'm going to say that again. They are going to need adolescent-specific care with transition into adult care. We need to get real and on this, particularly in Africa, and that's going to be my mission in the next 2 years, amongst a few other things. Retention and virologic suppression, you see here how we're doing in the under 1s, the 1 to 5s, the 5 to 10s, and the 10 to 15s, and then outcomes of perinatally HIV infected. So these are the kids who've grown up into adolescence. Not bad. Under 400 is about 77%. But again, this is an idea where there's quite a lot of concentrated care going on. Many of these are expert cohorts. We have to keep our eye on this. So within my 5 minutes, in summary, great progress in the last few years in South Africa in general. The Western Cape is doing well. I'm very proud of my province on a number of indicators. The picture in children is dynamic. It's changing. We have to be on it. The youth bulge is apparent here too. The new guidelines in September will obviously give us more work to do. Thank you very much to everyone.